Welcome to this medicine masterclass on diabetes insipidus. Diabetes insipidus occurs where there is a deficient production or ineffective action of antidiuretic hormone. This results in the passage of large volumes of urine, sometimes more than 3 litres a day, due to impaired water reabsorption by the kidney. It can be divided as either cranial diabetes insipidus, where the posterior pituitary or the neurohypophysis is not secreting antidiuretic hormone, or nephrogenic diabetes insipidus, where the kidney has an impaired response to the antidiuretic hormone. The patient will present with large volume polyuria, consequential polydipsia, dehydration, and as a result of the dehydration and the water loss, hypernatremia. The symptoms of hypernatremia include lethargy, thirst, irritability, and in extremis, confusion and seizures. The causes of diabetes insipidus, if we divide them as cranial and nephrogenic, can be idiopathic or tumours that can affect the pituitary gland, in particular a craniopharyngioma, a pituitary tumour, or a metastatic deposit. Infections such as meningoencephalitis can damage the pituitary gland. Surgery such as a hypophysectomy where the pituitary is removed, or a hemorrhage into this region, or autoimmune damage or infiltration can also result in cranial diabetes insipidus. Nephrogenic diabetes insipidus can occur when the kidney does not respond due to severe electrolyte derangements, or whether drugs such as lithium or dimethylcycline can affect the action of ADH. In order to investigate these patients, serum and urine osmolalities and sodium levels, as well as the water deprivation test and an MRI of the pituitary are performed. Serum osmolality is calculated. This is the sodium plus the potassium multiplied by 2 plus the urea and the glucose, and a normal serum osmolality is between 285 and 295 milliosmoles per kilogram. Urine osmolality can be twice this, around 570 milliosmoles per kilogram. Now, diabetes insipidus can be excluded if the urine to plasma ratio is more than 2, provided that the plasma osmolality is normal. So what we're trying to say here is if the urine is being adequately concentrated, then we can exclude diabetes insipidus. If, however, the serum osmolality is raised and the urine osmolality is decreased, i.e. the urine is very dilute and the serum osmolality ratio is less than 2, then that can suggest that the patient has ineffective or an inadequate response to antidiuretic hormone and the urine is consequently dilute. So a water deprivation test can be performed. This is an 8-hour test followed by a 4-hour test to determine if the kidneys continue to produce dilute urine despite being dehydrated. This is contraindicated in hypovolemic patients. First of all, confirm polyuria on a 24-hour urine collection. Ensure that there's more than 3 litres of urine being produced a day. Ensure that the urine osmolality is not more than 600 milliosmoles per kilogram, because if the urine is this concentrated, it's unlikely the patient has diabetes insipidus. The first stage is to ask the patient to empty their bladder. At this point, no further fluids are administered apart from dry food. Hourly weights are recorded, and urine is collected every 2 hours, measuring the volume and the urine osmolality. At the same time, venous serum osmolality is also recorded. The test is stopped 8 hours in, and the urine osmolality is measured. If, with being dehydrated, the urine osmolality is concentrated, more than 600 milliosmoles per kilogram, this is a normal response. But if, despite being dehydrated, the urine is still dilute, i.e. the concentration or the osmolality is less than 600 milliosmoles per kilogram, this is abnormal. And so we proceed to the second stage of this test. If at any time the serum osmolality climbs to more than 305, this would confirm diabetes insipidus and the test can be stopped. Or if significant weight loss occurs, for example more than 5%, then you can go directly onto stage 2. This would imply that lots of urine is being passed. The second stage is to help distinguish cranial diabetes insipidus from nephrogenic diabetes insipidus. Intramuscular desmopressin, which is an analogue of antidiuretic hormone, is given. The normal response would be, as a consequence of antidiuretic hormone, the urine osmolality climbs. In cranial diabetic insipidus, the urine osmolality would increase, and that's because in cranial diabetes insipidus, there's a deficiency of this hormone which is being exogenously administered, which has been corrected. In nephrogenic diabetes, irrespective of the exogenous administration, there's no increase in urine osmolality. And in terms of management, for cranial diabetes insipidus, find the cause, whether it's a pituitary tumour. This can be done through imaging, test the pituitary function, and give desmopressin, the synthetic analogue of ADH. If the patient has nephrogenic diabetes insipidus, treat the cause, stop any offending drugs, trial a thiazide diuretic and NSAIDs. This is treated in a multidisciplinary team through the endocrinologist and renal team. Thank you for attending this medicine masterclass.